Hello, everyone, and welcome to the lecture on depressive disorders of the DSM. This is much like the anxiety lecture and the chapter in the DSM. This is a very important one for clinicians. Whether you're clinical mental health, addictions, or school counseling, that you're gonna see a lot of depressive disorders in your career. So I would pay extra special attention to a lot of these disorders within the DSM. This, much like some of the anxiety disorders like GAD, the major depressive episode, depressive disorder. There's a few of them that you really need to pay attention to the criteria and even memorize, so that way you'll know when you see it. So let's get started. The first the first thing we're going to focus in on today is defining mood episodes and what actually a mood episode is. Let me reiterate here that a mood episode is not specifically a psychological disorder of the DSM. It's much like what a panic attack is. That we have panic attacks, but that's not a codable disorder in the DSM. We have panic disorder, which is, but before we even get to panic disorder, we have to define what panic attacks are. Uh, um, Same with mood episodes. Now, for this week, we're going to be looking at a major depressive episode, and then we move into bipolar and related disorders. We'll be looking at manic episodes. So, a mood episode, roughly defined, involves severe and enduring disturbances in emotionality, ranging from elation to severe depression. This week, we're going to be looking more at the depressive side. So before we can even assign somebody with a major depressive disorder, we have to see, in fact, if they qualify for a major depressive episode. So, and down below here are the criteria for what a major depressive episode looks like. Now, first and foremost, to qualify for a major depressive episode, that five or more of these criteria have to be present during the same 2-week period of time, and it also has to signify a change, a significant change in previous functioning. So, let's say, a month ago, that they had no depressive symptoms, but now they're having these symptoms all of a sudden, and it is different from where they were. In addition to having 5 or more symptoms within the same 2-week period of time, you also have to have at least one of the first two of the criteria have to be present in order to qualify for a major depressive episode. So either the person has to feel depressed, have a depressed mood most of the day, and or they have to have a diminished interest and pleasure in all or most activities of the day every day. So, and that's called anhedonia. So they have to meet at least one of these two criteria for it to even qualify as a major depressive episode. A lot of times they're just going to have both, but sometimes they might just have one, and if they do, then they're qualifying. Also, other criteria that they have to meet is they have to, to be part of the 5 at least, is they have to have significant weight loss or gain, which means they might be eating more or less than they used to. Insomnia or hypersomnia, so they're sleeping way too much or way too little. They might have psychomotor agitation or retardation, which means that they might be extremely fidgety, they can't sit still, they got ants in their pants, or they, on the other end of it, that they're a bump on a log, that they're just they don't move much. There's not a whole lot of, I guess just not a whole lot of movement. The 6th criteria talks about fatigue or loss of energy nearly every day. So they just, they have a really hard time getting up, getting out of bed, getting to work, having energy to do their work. They also have feelings of worthlessness or inappropriate guilt nearly every day. So, and this is going to be like, great feelings of worthlessness. Or inappropriate guilt about things or guilt about things that really isn't their fault or has nothing to do with them. They might also have cognitive issues. They might have a hard time thinking, concentrating on things. They might be very indecisive in their day-to-day planning, or in big event, big decisions, small decisions, and also they might also have some memory problems at this point. They have a hard time retrieving information. Recurrent thoughts of death, dying, and also suicidal ideation. Now, they don't necessarily have to have a plan and a means and a method and all of that. They might just be thinking to themselves, it just might be better, having these thoughts of, it would just be better off if I was gone, or I was dead, or so it's a range. So, within that. Additional criteria is that these depressive symptoms are not meeting the criteria for a mixed episode. Now, we haven't really talked about that yet, but mixed episode is having an episode of both depressive and manic features. So they can't have manic features and qualify, and also in order to qualify for a major depressive episode. This is also going to have just impairment in general areas of their life: work, their social functioning, relationships with other people. They might need hospitalization. They might also be having psychotic features. If depression gets bad enough, psychotic features can arise. Also, we have to rule out medications, substances, and also medical conditions as a cause of these depressive symptoms. So all of that needs to be worked out. Okay, so that is an actual episode, and that episode moves into what we call major depressive disorder. But before that, we're gonna start with we're going to start with disruptive mood dysregulation disorder. But these are all of the depressive disorders that we're going to talk about today, to some extent. Now, the first one, disruptive mood dysregulation disorder, is a new disorder to the DSM-5. This is primarily a childhood depressive disorder, or maybe adolescent depressive disorder. It's coded as F34.8, so that's a very easy F code to use, because there's not a whole lot in regards to having to code related to subtype or specifier or any of that. Now, like I said, this is more of a disorder that's going to be found in children. So I think school counselors need to pay extra special attention to this disorder, as well as clinical mental health counseling folks who are working specifically with pediatrics. So what this entails is a severe recurrent temper outbursts that's manifested either verbally and or behaviorally by the child, that's way out of proportion with the intensity or the duration of the situation. So these kids will fly off the handle, way beyond what the situation or the context of what they're dealing with it really demands. And before DMDD came on the came about, they used to look at depression with kids, as they would say that kids are typically very irritable when they're depressed, because they don't know that they're depressed, because they just don't recognize those feelings, and they don't feel good. So the only way they can express them is through irritability. So I think from that general concept of, hey, when a kid's depressed, they're typically irritable, has grown into a disorder called disruptive mood dysregulation disorder. Also, the temper outbursts are inconsistent with the developmental level that they're in. So as we're going to go through the criteria here, and there's different temporal types of criteria in terms of age and how many times this happens and stuff. But the thing is that when a 3-year-old or a 4-year-old has a meltdown, that's developmentally appropriate, because when you're 3 or 4 and you have meltdowns, especially given whatever context the child is in, if there's stressors that are above and beyond a typical that's typical to their developmental process, like if there's some non-normative event going on, that they will be more irritable. But we have to remember, we have to keep all that into account. But these kids are going to be a little older, and they're going to be having outbursts. That's way beyond where they should be developmentally. So these outbursts are going to occur 3 or more times weekly on average. So this isn't something that happens irregularly, or, oh, that's not really like them to do this. This is happening on a pretty regular basis, at least 3 times, at the very minimum. But this could be daily. This could be a couple times occurring each day. It can be pretty severe. But 3 times occurring weekly is going to be the minimum. The mood between the temper outbursts, the child's mood is going to be angry or irritable most of the time, nearly every day, and it's going to be observable by other people. So family, teachers, maybe the friends of the child, grandparents, whoever, they're gonna notice this irritable, angry mood that they have. Now, criteria A through D has to be present for at least a year, 12 months. And during this time, the child has not had a period lasting 3 or more consecutive months without all the criteria. So what they're saying is that you have to set up a pattern that, that if a child is having, let's say, a bad, couple of weeks, you don't diagnose with DMDD. This has to be a long enduring pattern of at least 12 months, 12 or more months. And during that time, they can't have any periods of remission any more than 3 months in a row. So what they're doing is they're looking for a pattern. If this is like, kind of sketchy and like, maybe, they'll have these symptoms for like a month, and then they'll, remit for a little while, and then they'll have these symptoms again for a month, then it's not DMDD. The criteria A and D are present at least 2 to 3 settings and is severe in at least one of these settings. So if a child, let's say a child comes from a family that's divorced, and the child has their dad's house, their mom's house, and then they have school and church. They have a lot of different settings that they're engaged in. But let's say the only setting that they're exhibiting some of these symptoms might be at dad's house, but not mom's house, not at church, not at school, not in Boy Scouts. That it's just one of the settings. Then you don't want to look at DMDD as a diagnosis. You want to actually look at, okay, what's going on at dad's house, and why are these behaviors and these meltdowns and the angry, irritable mood only occurring at dad's house. So that wouldn't qualify for a full diagnosis of DMDD. Maybe like an otherwise specified depressive disorder, if you want to stretch that. But once again, it might be more environmental and contextual in nature. The diagnosis should not be made for the first time before 6 years of age or after 18 years of age. So really, you're looking at a window of time between 6 and 8, and 17 or 18 that you're going to want to diagnose DMDD. And either by history or just observation, the age of onset for criteria A through E is going to be before 10 years of age. So, this isn't something that develops when you're 12 or 13 or 14. This has to be, these criteria, these signs and symptoms have to be present before the age of 10. So, it's kind of tricky with all of the temporal requirements that qualifies a child for DMDD, but you have to look at this very, very carefully when you're diagnosing, because if these symptoms are starting to occur after the age of 10, you might be looking at oppositional defiant disorder, conduct disorder, or some other kind of depressive disorder that might not fit too well into any diagnostic category. There can't be any kind of manic or hypomanic episode that the child has experienced, because anytime that somebody experiences a manic or hypomanic episode, that graduates them up to a bipolar disorder. So that's one of the things that you need to quickly rule out when you're doing a diagnostic assessment with a child. That if there's, or even with an adult, if there's any kind of manic or hypomanic profile going on, then you need to move away from just a depressive episode and start looking at the, it moving up to a mood disorder. Um, Also, that these signs and symptoms are not due to a major depressive episode from major depressive disorder or any kind of mental or other mental disorder. So you have to rule out other types of mental and emotional disorders to make sure that you're not actually looking at something else. And also you have to rule out the effects of substances and medical conditions that might be causing these symptoms as well. So there's a lot to rule out. And this is not, I don't think this is going to be a diagnosis that is going to, that you're going to be able to get to the bottom of in an hour's time. That there's going to be some real investigative work to do, observing the child and sitting with the child, also the parents. If you're in the school systems, hopefully you'll be able to just observe the child in their natural setting at school, talk to teachers, parent, so there's a lot that you need to do here. Now, there's disorders that that DMDD can exist with, and also that they should not be comorbid with. You cannot have a comorbidity. If you have DMDD, you have to make sure that you rule out ODD, IED, and bipolar disorder. These two, these three disorders cannot be comorbid with DMDD. But disorders that can be comorbid with DMDD is major depressive disorder, ADHD, conduct disorder, and substance use disorders. So this is an important slide to remember in terms of that you don't want to misdiagnose somebody with a comorbidity that the DSM is saying, no, in fact, that does not work that way. The main diagnostic features are going to be chronic, severe, persistent irritability with many temper outbursts. So once again, this can also very much replicate oppositional defiant disorder. So there's a lot of investigative work that you're going to need to be doing here. The prevalence is going to be a 1-year prevalence is 2 to 5%. So it's fairly prevalent. It's going to be found in mental health clinics that see kids, but it's also going to be seen in the school systems as well. And the school systems might not be might not be understanding what they're seeing with DMDD. When a kid's coming to school irritable and having meltdowns and angry, and they might will say, oh, the kids ODD, or they're a bad apple. Well, if it's DMDD, then that needs to be the school counselor needs to be able to recognize that and be able to say, okay, this could be this DMDD diagnosis. Let's send out for further investigation. It's going to be higher prevalence in males and also school-aged children. So, 7, 8, 9-year-olds are going to be, in elementary school are going to be, it's going to be prevalent within them. The onset really needs to be before the age of 10, that these symptoms need to be occurring before that time period. Symptoms usually lessen as individuals grow up, but also can transition into a major depressive disorder or anxiety in adulthood if they're not treated when they're kids. So it's going to be important to get these kids into some kind of a treatment, such as, one thing that comes to mind would be play therapy. I think play therapy would be extremely helpful with kids with DMDD. Some functional consequences to this disorder with kids is it's going to really have a disruption in the family in general and cause some very complicated dynamics within the family, and also their friends. I mean, they might not have a whole lot of friends if they are irritable and angry and having outbursts. That kids are gonna they're gonna see that, and they're not gonna want to be a part of that. Also, their academics will suffer. They might even have higher levels of suicidal ideation and attempts, and then just general aggression. If they're irritable and angry and losing their tempers, that they could lash out at other kids or adults or themselves. Some differentials, that there's going to be some overlap in criteria with DMDD with ADHD. So you want to rule out ADHD if to make sure that that's not what you're looking at. Also, bipolar disorder, that there's general irritability, outbursts, with bipolar disorder, and you want to make sure that in fact what they're what they're experiencing is not manic or hypomanic episodes. ODD and DMDD are very, there's a lot of overlap with, being irritable and angry and losing one's temper. And you want to make sure that, in fact, this is a depressive disorder and not an impulse control disorder, and also IED as well. So those are things that you definitely need to rule out. Okay, let's move on to major depressive disorder. I have provided you with a demonstration on Moodle that that is this YouTube clip. So if you haven't watched the YouTube clip, I would encourage you to pause this lecture and watch the demonstration first. This is an individual who talks about her depression and how it affects her day to day. So it's kind of gets you warmed up to what the diagnostic categorization of the DSM is saying. So the general criteria for major depressive disorder, I'm probably just going to call it MDD for the remainder here, is 5 or more of the following symptoms are present. So really what this is, the criterion A is really that you've had to have had a major depressive episode. You have to qualify for that. So if you've had a major depressive episode, then that means you are going to qualify for a major depressive disorder. That's the first criterion to qualify for that. So we've already gone over that, so I'm just going to move past that. Criterion B is that these symptoms are going to cause clinically significant distress and impairment in one's life, in areas of one's life. So so the distress is going to speak for itself in terms of, yes, these symptoms are ego dystonic to me. I don't like them. I want them gone, and also that they're influencing several areas of the person's life, that they can't. Their work performance has gone down. Maybe their academic performance has gone down. Socially, they're isolating themselves or just not reaching out to people. Things like that. Symptoms are not going to be attributable to biological effects of a substance or medical condition. So, that's part of the diagnostic assessment. You always have to ask, what medications are you on? What substances are you taking? And have you been diagnosed with a medical issue that could be contributing to this? And if they haven't had a physical in the last couple of few years, you want to get them into the doctor to make sure that something medically hasn't developed that could be resulting in these depressive symptoms. Also, you have to rule out other psychological disorders, such as psychotic disorders, because once again, if somebody's coming in with a severe depressive disorder, a severe major depressive disorder with psychotic features, you want to make sure, is this depression with psychotic features, or is this a psychotic disorder with maybe some mood issues attached to it, such as schizoaffective disorder? So. Also, you have to rule out that they have not ever experienced a manic or hypomanic episode. If they have, they are disqualified from having a major depressive disorder, and they graduate up to having a bipolar disorder. 2 categories of MDD. It's either a single episode event or a recurrent event. So the first time somebody has a major depressive disorder and they're diagnosed with it, that pretty much is, a major depressive disorder, single episode. Now, once they have another episode, then it's just going to be recurrent from there on out. So they've had a presence of 2 or more major depressive episodes. And also, and this is important as well, that the episodes that they've had have to be separated by at least 2 consecutive months where the criteria for MDD is not being met. So somebody might have their first episode of depression, which might have, let's say, lasted 4 months. And then after those 4 months, their mood gets better, and they become euthymic, and life is going pretty well for, let's say, at least 2 months, and then they experience another major depressive episode, which moves into major depressive disorder. So you have to have at least 2 months of reprieve between the episodes. If somebody, for example, has a major depressive episode, their first one, and they feel better for, let's say, 3 weeks, and then their symptoms come back, that's the same episode. So there has to be a distinction of a period of time that's at least 2 months where they feel better for those 2 episodes to be seen as 2 episodes. Severity specifiers, these are only for people who meet the criteria for a major depressive episode. They're used to describe the current clinical status if any features are present. So, this isn't like, okay, well, I had a major depressive episode a year ago. This is what are they experiencing right now? This is also based on the number of criterion symptoms, their intensity, and their level of dysfunction. So it's not just counting the criteria, it's also looking at the criteria in terms of how intense are they and how much is it impairing them. So a mild case is going to be just 5 to 6 depressive symptoms. The intensity is going to be low and there's mild dysfunction. Whereas severe is where most of the criterion are going to be met. The intensity is high and the dysfunction is severe. So maybe they're not going to work anymore. Maybe they have like profound feelings of inappropriate guilt and worthlessness. They have a suicidal ideation that is pretty severe, and they're experiencing a lot of these criteria. Now, the moderate specifier is somewhere in between, and it's really based on your clinical judgment. That mild and severe are somewhat spelled out for you, whereas moderate's like, well, there's a lot of gray area there. So you're going to have to use some analytical skills and discernment in terms of, okay, is this a mild case, a moderate, or a severe case? And be able to back it up with your clinical assessment. Okay, there's also a feature with psychotic features. So when somebody gets depressed enough and it's severe enough, they can have delusions and or hallucinations during this time, and which usually requires hospitalization. So, but these psychotic features can either be mood congruent or non-mood congruent, or I guess mood incongruent. So when they're mood congruent, that these psychotic features, are consistent with some kind of typical depressive theme. So they might have delusions of worthlessness, guilt, death, nihilism. It's still coloring within the lines of their depression. Their hallucinations might be related to some kind of depressive feature or theme to it, whereas the mood incongruent psychotic features, these might not be at all or partially consistent with typical depressive themes. So, they might have delusions and hallucinations that are completely outside of the depressive theme. So they might have a delusion that the FBI is out to get them, or that aliens have, possessed their minds, things like that have nothing to do with depression. So when somebody is, this far along in their depression, typically they're going to be hospitalized, and you won't have unless you're working in the hospital, you're not going to have too much contact with them at this point. But if you do, just know that with psychotic features specification does have mood congruent or incongruent psychotic features. So some further specifiers, if the criteria is not met for a major depressive episode, let's say somebody comes in, you diagnose them with MDD. They've been in therapy for 3 months. They're maybe taking an antidepressant, and you reassess them for their symptoms, and you figure out they might be in partial remission, which means that only some symptoms of the previous episode are present, and also or there's less than 2 months where no symptoms are present from the previous major depressive episode. So either after a few months of seeing them in therapy, that either a lot of the signs and symptoms have decreased, or they've all decreased, but not for any longer than 2 months, that you would give them an impartial remission specifier. Now, after 2 months, if there's no depression going on, then you would give in full remission. And I think this is an important distinction to make, in terms of when you submit diagnoses, that if you're working with insurance, then and you give somebody, let's say, a major depressive disorder, moderate symptom or recurrent moderate symptoms, then you want to, after so many months, if they've gotten better, that you want to resubmit that diagnosis so the insurance company does know, hey, they're in full remission or partial remission. So there's other specifiers that can also make the diagnosis more idiosyncratic or specific to the client. And I think this is important to do, that it will make it, it's just going to make it more detailed, so that way you know how to better plan in terms of treatment. So they have one with anxious distress, mixed features, melancholic features, atypical features, catatonia, peripartum onset, and then also seasonal pattern affect. Now, these are all described in the DSM, so I would strongly recommend reading through those, understanding how they look, and knowing that they're there when you do assess and diagnose people. Also the thing is some of these specifiers, like atypical features versus melancholic features, are going to respond to psychotropic medications in different ways. So if so that's going to be important to know. If somebody's coming in with melancholic features versus atypical, that, hey, one is going to respond to medication a lot better than another. And and also with anxious distress, if somebody's coming in with maybe not the criteria for an anxiety disorder, but they have significant anxiety, then hey, that's something else to take into account for treatment for talk treatment plans for talk therapy and for medication therapy. Coding procedures are pretty straightforward. That I think the first thing you have to look at is is the diagnostic is for major depressive episode, is it a single or recurrent episode? If it's single, you would use this column. If it's recurrent, you would use that column, and then it would go by moderate, and it would go by severity. In terms of, is it a mild case, is it moderate, severe, or with psychotic features? And then once you re-diagnose or revisit the diagnosis after several months, if change has occurred, that you would give them, an impartial, full, or an unspecified remission. So it's pretty clear cut, and the book is I'd say the book is very easy to use. It's very user friendly. So some coding examples on how you would actually write out a diagnosis is you would start with the code first. So if this is a major depressive disorder, recurrent, moderate with anxious distress, that would be F33.1, because once again, if it's major depressive disorder, recurrent and moderate, F33.1, and anxious distress has no bearing on the F code. So those specifiers, that has nothing to do with the F codes. Another one, F32.4, major depressive disorder in partial remission. So you might give this disorder to somebody, and then after 6 months, you reassess. And if they're in partial remission, you would give them, you would re-diagnose them with this. Also, F33.3, major depressive disorder, recurrent, severe, with psychotic features. So, there's just another example. Some differentials for MDD. You would want to rule out ADD or ADHD, substance-induced depressive disorder, because if they're taking a substance that might be causing a depressed mood, make sure that you do that. Same with mood disorder due to another medical condition, that you want to make sure that you're not looking at hypothyroidism and trying to treat hypothyroidism, or trying to treat MDD when it's actually a medical condition that talk therapy is not going to talk them out of. And also adjustment disorder. That's another one you need to rule out, because a lot of times there's psychosocial issues going on in someone's life that they just haven't been able to adjust to. And if they're experiencing distress from that life transition, then they might be having an adjustment disorder with depressed mood. So major depressive disorder can be comorbid with a number of different psychological disorders. Substance use disorders are, that's right up there. However, once again, you have to make sure that the substance that they're using isn't causing the depression, that the depression has to in fact be independent of the substance use disorder. So if they stop taking the substance, the depression should continue on. So that's that's one of the things that you have to think about in terms of, well, when did they start using the substance? When did they start feeling depressed? There has to be a timeline that is occurring here, that one isn't causing the other. Also, OCD. Somebody can have obsessive compulsive disorder and a major depressive disorder concurrently. Anxiety disorders, eating disorders, and personality disorders all can be comorbid with major depressive disorder. All right, let's move on to substance medication-induced depressive disorders. I'm going to kind of skip through this because there's a lot. I think there's a lot of disorders in the DSM, a lot of chapters within the DSM that have this part, that have this disorder give it to their respective disorders for their respective chapters. So anxiety disorders had one. Now depressive disorders are, and you have to make sure if you do an assessment and you figure out that the substance or medication that the person is actually taking is causing their depressive symptoms, then you would diagnose with this. So somebody comes in and said, I'm depressed, I don't enjoy things anymore, I think I'm depressed. And when you actually do the history, give them an exam or the lab findings, that and you find out that, hey, this is the medication is causing the depressive symptoms that you're that you're experiencing, you would diagnose with this. Once again, it's not better explained by another depressive disorder that is not substance or medication induced. So once again, you have to rule out major depressive disorder, persistent depressive disorder. You have to rule out delirium, and you also have to see if this is causing significant distress and impairment in life. So if you have to specify in terms of if the onset was during intoxication or during withdrawal. If let's say if we're looking at alcohol as a substance, we would say alcohol-induced depressive disorder, and if it's with use, the disorder is mild. It would be if it's with use disorder or with a use disorder or an alcohol use disorder, but it's mild, you would diagnose F10.14. And the 1 would signify that it's with a use disorder and it's mild. If it's moderate or severe, it would be F10.24. And if it's without a disorder, then it would be F10.94. Now, typically, I guess I'm gonna go on a limb here and say that if you are dealing with and this might be more for addiction counselors, that if people are coming in and they're depressed and significantly, and if it's with and they've been using either, let's say, cocaine or alcohol or whatever, then that you're going to be the ones that are making these diagnoses more than, let's say, school counselors or even clinical mental health counselors. But these are the people that are going to be coming in for treatment for partial hospitalization or full hospitalization, 30-day programs, and they're coming in, they've been using, and maybe they've been using a lot, maybe they've been using a little. I'm going to say that the majority of people that are coming in for treatment, they're either going to have a moderate or severe diagnosis. So F10.24 is going to be, okay, you have a use disorder, you have an alcohol use disorder that's moderate to severe, but you also are depressed, or you're exhibiting depressive symptoms. So for now, we're going to give you, an alcohol-induced depressive disorder, and see, does the depression continue after several months of non-use. If the substance use disorder criteria is not met, simply list the depressive disorder and the specifier. So these are just some examples. So if it's a cocaine-induced depressive disorder with onset during withdrawal, let's say somebody goes out and just uses cocaine one night, and they're depressed after that, and let's say they're hospitalized, then then you would then you would give them this I would say somewhat rare disorder. But let's say somebody has been using for a while, and they do have a substance use disorder criteria, this is what it would look like. So let's say it'd be F14.24, moderate cocaine use disorder with cocaine-induced depressive disorder with onset during withdrawal. So this is going to be important for people who are coming in to treatment, let's say with a cocaine use disorder and it's moderate. Okay, you want to diagnose them with that, but then also tack on the depressive disorder as well, because because it has caused them depression due to their cocaine use. And this next one is really depressive disorder due to another medical condition. This is when somebody's depressed because of some kind of a medical condition that they have. So what you would do, the coding notes, if there's three specifiers that are used. If it's with depressive features, meaning that the full criteria for MDE or major depressive episode are not met, that is just depressive features. However, if somebody's coming in with major depressive-like episodes, that the full criteria for an episode is met, so you need to say, okay, they have, they have depressive-like, that it's depressive-like episode. And then with mixed features that have mania and hypomania symptoms, but are not present, symptoms that are present but not dominant. So this is when somebody might have, mixed features. They have depressive symptoms, they have manic symptoms, and it's all related to a medical condition that they have. So here's how you would code a depressive disorder due to another medical condition. So you would list the name of the medical condition. So in this case, it would be hypothyroidism. And then you would code it F06.32, depressive disorder due to hypothyroidism with major depressive-like episode. But once again, I don't think this is a disorder that typically you're going to be diagnosing. That I think if somebody comes into your office and says, I've been feeling depressed for the last year and a half, and I have all these symptoms, and you say, okay, go get a physical, and they come back and say, well, they've just diagnosed me with some pretty severe hypothyroidism, and then say, okay, well, get treated for that, and then see if your depressive symptoms go away. And then they do, and then their depressive symptoms go away. Like, I guess you could diagnose them with this, but chances are they're not going to come back to see you anyway, because it's a medical condition, it's not a psychological condition. Okay, we have other specified depressive disorder. This is, once again, like other specified anxiety disorder, this is a catch-all basin for people who do not fit into the criteria of major depressive disorder, persistent depressive disorder, DMDD, that they're feeling it's, that maybe there's a time requirement that they didn't meet, or a number of criteria that they don't make. But you have to diagnose them with something, because what they are experiencing is causing distress and impairment. So you would give them other specified. And then the clinician would provide written explanation for what is specifically missing, or how it's in fact affecting them. Whereas the unspecified depressive disorder, you just don't, you wouldn't provide a written explanation. I think for the most part, I think, unspecified depressive disorder is going to be better for, hospital admittance to the ED. Whereas if you're seeing somebody in a community mental health setting, and you give an insurance company the code of F32.8, they might want some written explanation as to what's going on with these folks because they've been given the other specified disorder, and in order for reimbursement. So I would always go with this if you can, and I would say that in our field, that we're going to use that more often. All right. Okay, next we're going to look into persistent depressive disorder, and which is a nice code. It's F34.1. It's easy to code. This was formerly referred to as dysthymia in the 4th edition, and they've renamed it persistent depressive disorder in the 5th edition. So I just want you to know that if I refer to it as dysthymia, that's why, because first of all, it's easier to say. And it's what a lot of us know it as. So dysthymia is I don't think it's as severe as in terms of major depressive disorder, but it certainly is more lengthy in terms of a disorder. I have a picture of Eeyore here because Eeyore is maybe one of the perfect examples of what dysthymia is. You know, it's you're not completely laid out, or from a major depressive episode. You know that you do have more functionality, but your depressive symptoms are like they're more dysthymic. They're more like low level types of depression that's not as dark as depression, but they last for a long time. You know how Eeyore would always say, "Nothing's wrong, everything's fine." That's just generally the dysthymic mentality. So this is when somebody has experienced a depressed mood for most of the day, more days than not, for at least 2 years. But being depressed, having a depressed mood, is a lot more. It's not as severe. So while they're depressed, they have to have at least two or more of the present. That they might have a poor appetite, or might be overeating, eating too much or too little, sleeping too much or too little. They might have low energy or fatigue. They might have low self-esteem, poor concentration, indecisiveness. A lot of this is really, it's kind of like the more shallow, or more the less severe signs and symptoms of depression. Maybe even feelings of hopelessness. So, oh, I'm sorry. So, two of these six have to be present. Now, notice that the excessive worthlessness and inappropriate guilt are not there. Notice that the suicidality is not there. That this is just kind of the more shallow level of the pool of depression. During these 2 years, a person has not been without meeting the criteria A and B for more than 2 months at a time. So they can't have more than 2 months of reprieve, at 2 consistent months of reprieve within that 2-year period. These symptoms have to be pretty continuous. The criteria for a major depressive disorder may be continuously present for these 2 years. So let me give you a little bit of a backstory about this. In the DSM-4, dysthymia and major depressive disorder were mutually exclusive, that you could not have both of these disorders at the same time. And now what they've done is they've conjoined them together. That says that you can have a major depressive, or meet the qualifications for a major depressive disorder and dysthymia at the same time. There's also never been a manic or hypomanic episode, and we haven't gone over cyclothymic disorder yet, but once again, any kind of manic, hypomanic, or mixed episode that someone experiences, that disqualifies them from any kind of depressive disorder, and it moves them up into the bipolar and related disorders category. So always assess for that. It's easy to do, but you have to make sure that you do it. It's also this disturbance does not occur exclusively during a chronic psychotic disorder. So for a disorder like schizoaffective disorder, there's a mood component to it, that you want to make sure that you're not misdiagnosing dysthymia as part of the mood component of schizoaffective disorder. Also, this isn't due to a substance or a medical condition. That this has to stand independent of both of those things. And of course, these symptoms are going to cause distress and impairment in areas of their life. Specifiers for dysthymia are going to be pretty much the same as major depressive disorder. So all of the types are going to can be associated with dysthymia. Severity, mild, moderate, and severe. You would definitely look up what those criteria are for dysthymia, and also the course in terms of partial or full remission. Now, the onset for dysthymia, there is an early versus late onset. That if onset occurs before the age of 21, then you would do an early onset. If it's after 21, then you would do a late onset. And let me also just say that once again, an early onset of this disorder will most likely result in a more guarded or poor prognosis for treatment or for recovery. There's also some specifiers for the most recent bout of dysthymia. There's a specifier of with pure dysthymic syndrome, which means that a major depressive episode criteria has not been met over the last 2 years. There's the with persistent major depressive disorder, that a major depressive episode criteria has been met over the last 2 years. And then with intermediate major depressive episodes with current episodes. So a major depressive episode criteria is currently met, but there have been episodes of at least 8 weeks where it hasn't been met over the last 2 years. So that means that there's a major depressive episode that occurs for a while, but then it remits, and then it remits for at least 2 months, and then another one might occur. And then, and it's going to go in waves. Whereas with the first one, with persistent major depressive disorder, that they have experienced a major depressive episode pretty much the entire time over the last 2 years. And then the last one is with intermittent major depressive episodes without a current episode, is that they're coming in without a major depressive episode being met, but there's been at least, they've met the criteria for at least one during the last 2 years. So these specifiers, you just have to get them straight in your mind. But once you do, it's not that hard. Okay, so some coding notes. These are just some examples of how it would look when you diagnose somebody. That the F code is fortunately going to be the same, F34.1. And persistent depressive disorder is going to be that's going to be the diagnosis, but then the specifiers and the severity levels are all going to be different. So you have persistent depressive disorder, mild, late onset, with anxious distress, with pure dysthymic syndrome. So that's one combination. If they meet, after doing a diagnostic assessment, if they meet, all of that, then you would diagnose with all of that. Same with persistent depressive disorder. This one might be a severe case, early onset, with melancholic features, with intermittent major depressive episodes with current episode. So once again, the thing I like about these specifiers and types and severity levels is that it really does help to demonstrate that two people can come in and both have persistent depressive disorder, but it can look very different in the clinical profile, but it's still the same disorder. So I think this is where the DSM really needs to go in terms of helping to specify and make each disorder a little bit more idiosyncratic for everyone. Because what that's going to do is it's going to help specify the treatment and the conceptualization. So dysthymia in and of itself, it's going to differ from major depressive episodes in its severity, how chronic it is, and number of symptoms. They're milder symptoms, but unfortunately they last longer. So that's the trade-off, that if you have a major depressive episode, it might only last 3 or 4 weeks, or maybe in a couple months, but then it goes away. Whereas dysthymia kind of comes on and it's with you for years. The median duration of a dysthymic episode is about 5 years in adults, 4 years in children. So it's pretty profound. Almost 3/4 recover at some point with a 71% relapse. So there's a lot there. These folks are more likely to attempt suicide than individuals with a major depressive disorder. And one guess that I would have is because of this, is because it's so, it's so lengthy that they get ground down by it. But then also they have more energy to actually attempt suicide than somebody with a major depressive disorder. Because usually when you have a major depressive disorder, you're just wiped out, and you're too fatigued and wiped out to even think about suicide. Okay, so let's move on to a new diagnosis in the DSM-5. N94.3. Don't ask me why that they've classified it as an N code and not an F code. I still haven't figured that out yet. But it's called premenstrual dysphoric disorder. And there, I think there's about 5 criteria that an individual needs to meet for this. So the first criteria is in the majority of menstrual cycles that a woman experiences, at least 5 symptoms have to be present in the final week before the onset of their menses. Uh, and then they begin to improve within a few days after the onset, and then they become minimal and absent in the week post menses. So, and this graph, I mean, this is kind of a goofy graph that I made, but it just kind of gives you a visual that the week before, these symptoms are ramping up. They peak right at, during the time of menses, and then they go back down. One or more of the symptoms have to be present here. The individual experience affective lability, like such as mood swings, irritability or anger or increased interpersonal conflicts, depressed mood, hopelessness, self-depreciating thoughts, anxiety, tension, feeling keyed up or on edge. One or more of these symptoms have to be present, totaling 5 when combined with criterion A. That they have to have a decreased interest in usual activities. So they have like this temporary bout of anhedonia. They have a hard time concentrating, feeling fatigued, lack of energy, change in appetite, sleeping too much or too little, feeling overwhelmed, feeling out of control, and then also having a number of physical symptoms. Also, criteria A and C must be met for most menstrual cycles for the last year. So this isn't somebody coming in saying, yeah, the last 2 periods I've had these symptoms. This is over. I think the clinician needs to derive that there has to be a general trend going on here. And I remember I worked with an individual who we diagnosed this with, and when we finally came upon this and we started to assess for it, yeah, the individuals, the client said, yeah, I've been having these problems since I was like 17 years old, and she was in her 30s. So the I guess the pattern was well established at that point. This is going to cause distress and interference with life. This is not an exacerbation of symptomology from another mental disorder, but it could occur in conjunction with other disorders. So the client that I was working with premenstrual dysphoric disorder, she also was diagnosed with borderline personality disorder, and we had to determine whether are these symptoms just an exacerbation of the borderline personality disorder, or are they in fact something independent of themselves. And I'm not sure if we ever got to that point, because it was I can't remember. It was so long ago, but it was that was something that we had a long conversation about, in terms of, did she think that this was part of her bipolar disorder or her borderline personality disorder, or if this was something in and of itself. And I think because maybe it went back so far that maybe we were thinking it was more the dysphoric disorder. The symptoms really should be rated for 2 symptomatic cycles. So even though that she had all of this history, that it was still prudent to to go through those next 2 months and her to write everything down, and as she experienced those symptoms, to see in fact if she did meet the criteria for them. Also, we have to rule out substance use and other medical conditions as well. Okay, so that does it for the actual uh, disorders part of the lecture. And I'd like to move briefly into etiology, prevalence, and treatment of depressive disorders in general. Now, the etiology of depression is going to be just about the same as the etiology of just about every other psychological disorder. It's there's so many different etiologies. 2 people could be coming to see you for, let's say, the same diagnosis of major depressive disorder, but they're going to look differently in the profile. But their etiologies could also be very different in terms of how they developed it, because there's many roads to the same disorder. So there's the biological etiology. They might have a genetic or disposition to it, according to the diathesis stress model. Their epigenetics might be at play here as well, in terms of how they've been activating or not activating their epigenetic code. Biochemistry is more the functionality of depression. For example, I would say my guess is that melancholic depression might have a little bit more of an interplay of the biological biochemistry of the depression profile versus, let's say, atypical depression. So so that's all going to be different. The psychological etiology, personality structures, learned behaviors, trauma. I mean, trauma can be a profound etiology for depression. Family dynamics can be an etiological factor in terms of also in terms of also environmental and social changes, and also larger sociocultural issues like the larger social narrative, systemic oppression, all of these things in conjunction with one another. I wouldn't look at it as picking 2 or 3 of these out and then attributing to a person. I would say all of these are probably to some extent at play. You just have to figure out how, and if you're kind of thinking about these as all ingredients as to how they're cooking up their depression, what's the level of ingredients? What, like, how much trauma has the person experienced that's an ingredient of depression? How much of their biochemistry is an ingredient for this person's idiosyncratic depression? How much of systemic oppression contributes to an ingredient, as one of the ingredients of the person's idiosyncratic depression? So I think if we can better understand the etiology of it, at least on a conceptual level, that we're going to be able to have a clear idea in terms of where to go with treatment, whether it's talk therapy and or medication therapy, or maybe some other things. Some fun facts of depression: incidence of depression and consequent suicide is increasing overall in our society. Young Americans or younger Americans over the last several decades have an increased risk of depression. Once again, what's the etiology of it? You have to think about the etiology, and that's a whole other conversation that we could be having. Quarter of people 18 to 29 have experienced MDD in at least in one study, so that's a significant portion of that age group. Early onset before 21 is associated with a more chronic case of depression, a poorer prognosis, and a stronger biological predisposition for depression. So, those are some things to keep in mind. There's a higher prevalence of dysthymia in children, whereas over 3/4 of dysthymic children later move into a major depressive disorder diagnosis. Some prevalence for major depressive disorder, 6.5%, 6 to 12 months, over a lifetime, 16%. Dysthymia is about a little over 3%, which is a lot less. And then bipolar disorder, fortunately, is at around 1 to 1.5%. So women are twice as likely to develop major depressive disorder and dysthymia than men. Once again, though, it makes me wonder if women are just more willing to seek out help than men, and men just suffer in silence. African Americans have a lower rate of major depressive disorder and dysthymia than Caucasian and Hispanic populations. Fair to poor health status was a strong predictor of depression in African American populations. Some anxiety fun facts with depression. Almost all depressed people are anxious, but not all anxious people are depressed. So you have to think about that. When somebody's coming in who's depressed, then you also want to do a pretty heavy assessment on anxiety as well. Here's a chart about pure anxiety symptomology, pure depression, and then a mixed anxiety and depression. So once again, these are just symptoms that might be more attributable to just anxiety and just pure just depression. But then in the middle, where they kind of come together, then there's things that you want to also take note of as well. Treatment of mood disorders. General treatment is, it's going to hopefully be a combination of medication, if needed, and talk therapy. And I say medication if needed is there's a lot of people who don't want to take medication. That I firmly believe that there is a biological depression form of depression, and there's a psychological form of depression, and maybe there's other forms of depression but then there's also a biopsychal form of depression, that there's a combination of a biological functionality and a psychological functionality. And sometimes I've worked with people who were severely depressed, and they took every medication known to the mental health world, and none of them worked. Whereas other people respond well to the medication. So there's a lot of different ways that depression functions in the mind and the brain. Is it a mind-based depression? Is it a brain-based depression? Is it a relationship-based depression? What's going on here? And I think if we can understand the etiology and functionality of it on our part, then the treatment should line up with that. For medication, though, there's a couple of different families of antidepressants. There's tricyclics. This blocks the reuptake of certain neurotransmitters, which allows them to pool in the synapse and downregulate the transmission of that particular neurotransmitter. So tricyclics are an older form of antidepressant. They have a pretty decent effectiveness rate, but they have a lot of side effects as well. They're also one of the most researched. MAOIs, that's pretty much the first family of antidepressants. They can be effective. They do have less side effects, but the side effects that they do have can be very severe. So typically MAOIs aren't used that much anymore. SSRIs are still pretty widely used, blocking the reuptake of serotonin in the brain. This is going to be one of the maybe the first choice of treatment for depression, and they have the lesser side effects. New generation antidepressants are also on the market and are widely used with less side effects. And the new gens actually have a different functionality of the SSRIs. Okay. Treatment for depressive disorders can be very wide based. Now, cognitive behavioral therapy is one that is going to be seen under best practices. Is that it's an evidence-based treatment that researchers have demonstrated that it is fairly effective or pretty effective in treating depression. Once again, a lot of different types of depression in terms of etiology and functionality that CBT sometimes may be able to treat, and other times not. So if, let's say, the depression is, let's say, trauma-based, I don't know if I would just use pure CBT to treat that, because you're not resolving the trauma. If it's biologically based, then CBT is going to need a little bit of help from medication. There's interpersonal and social rhythm therapy. Family therapy. I mean, there's a lot of different kinds. So I think part of it is just determining, first off, like what do they have, diagnosing them with with what the person qualifies for, and then figuring out what's the etiology, the conceptual etiology, and the conceptual functionality, and then moving forward with that in terms of, okay, well, that your depression seems to run in your family, so maybe getting you on a medication might be the best way to go, and with some psychotherapy. Whereas if this is purely trauma-based, then you might want to move into a trauma treatment, with maybe some medication serving as a window of opportunity. I guess there's too many different ways of looking at a treatment within just this lecture, but I would be open to the idea, if I were you, that treatment can look a number of different ways. You just have to get a firm understanding of what the depression actually looks like and what it is. All right. So this is the end of the lecture for depressive disorders. If you have any questions, please reach out. If not, have a great week.